Welcome, and thank you for joining us today to discuss this important topic of maternal health, improving outcomes and reducing disparities. I'm Dr. Amy Banulis, a board-certified OBGYN with the Mid-Atlantic Permanente Group. And I'm joined today by my incredible colleagues, Dr. Kristin Knight, Dr. Carla Sandy, Dr. Ada Emarievbe, and Dr. Trashawn Thornton-Davis. We are very excited to be talking to you today.
Good afternoon, everyone. I am Dr. Kristin Knight. I am a board-certified OBGYN and maternal fetal medicine physician practicing in Northern Virginia.
Good afternoon. My name is Dr. Carla Sandy. I'm a board-certified OBGYN and I practice in Silver Spring, Maryland.
Hi, everyone. Good afternoon. My name is Dr. Ada Emarievbe. I'm a board-certified OBGYN out of the Baltimore service area.
Good afternoon, everyone. I am Dr. Trashawn Thornton-Davis, and I'm also a board-certified OBGYN practicing in Silver Spring, Maryland.
All right, thank you all. So promoting health along the whole continuum of preconception, pregnancy, childbirth, and postnatal care is very crucial. Every stage should be a positive experience, ensuring all women and their babies reach their full potential for good health and well-being. However, despite medical advances, the rate of maternal mortality is rising, which recent data shows has been exacerbated by the COVID-19 pandemic. According to the CDC, over 700 women die each year in the US as a result of pregnancy or delivery complications. We also know that significant racial disparities exist in maternal health. In 2020, Black women were 3 times more likely to die from a pregnancy-related cause than white women. There are multiple factors that contribute to these disparities, many of which we'll touch on today. Our goal is to provide meaningful information about the journey of motherhood and potential strategies to improve health outcomes and reduce the disparities that we see. We are looking forward to your questions. So if you are watching live, please post them in the comments on Facebook. So let's dive in. And I'm going to start with Dr. Carla Sandy. Can you provide an overview of what we mean when we say maternal health? At what point in a woman's life do we start to talk about her well-being in pregnancy and postpartum?
Yeah, that's such a great question. You know, maternal health really encompasses the entire woman, her support system, everything that she has as she enters into those, reproductive years, when she becomes pregnant, and after pregnancy, when she gives birth. We really start talking about maternal health when women start visiting an OBGYN. Every aspect of your health can impact, your health when you are pregnant and having a baby. So we start talking about things like high blood pressure, like diabetes, like healthy eating, like maintaining good cardiovascular health with exercise. Things like that are very important. There are also other things you may not think about, things like making sure you don't have certain infections, making sure those are treated, all of those things. And then stress management, right? Your mental health is super important, and making sure that you're in a good mental space, to embark on a maternal health journey. And often, women worry, they're like, oh my goodness, I didn't dot all my I's and cross all my T's before I got pregnant. What does this mean for me and my baby? And, all hope is definitely not lost. That's what we're here for. That's what we're here to guide you through that process and to basically optimize your health. So if you're thinking about maternal health and what it means optimizing your health, getting to the best place you could possibly be.
Thank you, Dr. Sandy. And kind of piggybacking on that, Dr. Emarievbe, what are the most important lifestyle changes a woman should make when she's contemplating pregnancy?
Yeah, I think Dr. Sandy highlighted a lot of what we discuss with our patients as it pertains to lifestyle changes. Most women show up and maybe they didn't go to preconception counseling visits. In an ideal world, it's really hard when you think about access and time and the ability to really plan your pregnancy. Preconception visits are a really great way to sit down with your OBGYN prior to getting pregnant to look at what are some things that are happening now in my life that I need to change before I get pregnant. But to Dr. Sandy's point, a lot of times, our women show up and they're already pregnant. But there are still things that women can do to increase their chances of a successful pregnancy and delivery. We know that a healthy weight increases your chances of a more positive outcome when it comes to delivery, when it comes to pregnancy. So we really encourage our patients to make sure they have a balanced diet full of fruits and vegetables, everything that we learned as children, eating our vegetables, eating our fruit, being very mindful of those sugary, high carbohydrate diets, very ultra processed foods are really not going to be beneficial when we look at weight management. Also exercise. I know that when my patients come to see me, they get really concerned about, oh, can I exercise while I'm pregnant? I don't want to hurt the baby. I don't want anything to happen. And actually the National Institute for Health encourages at least 150 minutes a week of exercise. And that can be walking, that can be, brisk walking, that can be Zumba class, that can be, a nice ride, depending on how far you are gestational age. But, I have some patients who still like riding their bikes and they're in their late second trimester. So whatever gives you that cardio that's going to allow you to have physical activity, which is highly recommended. Dr. Sandy talked about stress maintenance. That's really important. A lot of women who are pregnant are working. They may have a growing family already, little ones at home. So managing all of those things is really important. That means stress at work, stress within family, and your mental health, which I know we'll talk about a little bit later. And then, smoking, alcohol use. These are all things that you would think, go without saying, but it's really important for our patients to understand that smoking does increase adverse effects to our babies. So making sure that prior to or at the time of finding out you're pregnant, you stop or make efforts to stop smoking. And obviously use of illegal drugs is something that we strongly encourage to stop either before, during planning of pregnancy, or at the time that you find out you're pregnant.
Great. Thank you, Dr. Emarievbe. All really good points. And then I'm going to move on to Dr. Knight. What are the most important first steps for a woman to take once she conceives? And if you can touch a little bit on some pre-existing medical conditions that can impact pregnancy and how you manage those.
Yep, absolutely. Thank you. Really, the most important first thing to do is for a woman to contact her OBGYN and to highlight what Dr. Emarievbe said. Very important to stop smoking if you are smoking, if you haven't stopped before becoming pregnant, stop drinking alcohol. But one thing I want to highlight is a lot of times women with chronic medical conditions will stop their medications when they find out that they're pregnant. And there's a small number of medications where your doctor may plan ahead of time with you to stop when you become pregnant. Unless that is the case, which is not the case for most medications, it's actually important to keep taking what you're on and get in touch with your OBGYN. What a patient's OBGYN will do is review her medical history, her pregnancy history, identify what risk factors she has for developing complications in the pregnancy, and then implementing a plan to mitigate those risk factors or those risks when possible. One of the most common things that we do is start women on low-dose aspirin in pregnancy to reduce the risk of certain complications. Speaking of medications, the OBGYN will review a medication list, determine what medications should be continued, which should be stopped, which may be changed to a different agent that has a more favorable safety profile in pregnancy. So really important that a woman has her OBGYN's input before making those decisions, because what we don't want is to stop medications and then all of a sudden have uncontrolled seizures or hypertension or other chronic illnesses. In terms of pre-existing medical conditions, really, the most common pre-existing medical conditions that we see are high blood pressure, diabetes, obesity, and really the key is to do an assessment of where the patient is at that point in time and make sure that we're doing everything we can to optimize her health. Any uncontrolled chronic illness can increase the risk of pregnancy complications, and we can actually mitigate those risks by controlling disease well. So that looks like controlling blood pressures, controlling blood sugars, staying on medications to reduce the risk of a lupus flare, those types of things. And I think both Dr. Sandy and Dr. Emarievbe talked about controlling weight. So it is ideal to attain a goal BMI prior to pregnancy, but once a woman becomes pregnant, we actually don't want her losing significant amounts of weight. Ideally, we want her to either gain weight or stay the same. For some patients, that's appropriate. But for patients who do become pregnant and their body mass index is higher than ideal, we can talk about strategies to avoid excess weight gain. So essentially, that initial touch point with the OBGYN is to do an overall assessment of the patient's level of risk, create a plan for how to manage the pregnancy, and really maximize the chances for a great outcome for mom and baby.
Great. Thank you so much, Dr. Knight. And then turning to Dr. Thornton-Davis, how do you recommend that a woman kind of self-advocate during pregnancy? What are some of the questions that she should be asking along the way? And then how do you really kind of foster that trusting relationship with your own patients?
Yeah, so the provider, whether your provider be a physician or a midwife, the relationship that a woman has with her physician or midwife is really important. I oftentimes equate it to a marriage, really, right? You want to make sure that you find someone who understands you, who listens to you and hears you, and addresses the concerns that you may have. So I usually recommend that my own patients come in with a little book, a little notebook, and write down questions that they may have as the trimesters pass, because once you get into the office, you may forget. As the doctor's leaving, you may say, oh, I forgot to ask this. So it's best to, before you go in, do a little homework and write down questions that you may have. The first trimester, which usually ends at about 14 weeks, I usually will tell my patients to ask questions such as Dr. Knight mentioned before, are my prescription medications safe to take? So before you just, stop your medications, you want to ask, hey, is this safe to take? Because we also want to balance controlling whatever chronic medical conditions you have with the pregnancy. Another great question to ask in the first trimester is, am I at risk for any complications? So everyone's a unique individual, and you want to find out, based on your history, your medical conditions, what your risks are and what you could do to help to mitigate those risks while you're pregnant. Another question, and I think Dr. Emarievbe talked about this earlier, is how much weight should I gain? What's a normal healthy weight gain based on my BMI when I, became pregnant? And then what exercises are safe? Like, what can I do in pregnancy? And, it can vary by trimester. What's safe for me to do during pregnancy? Another good thing to think about if you've had a previous C-section and you're in the first trimester is, can I VBAC? Or VBAC stands for vaginal birth after C-section. Am I a candidate for that? And if so, what do I need to do? What do I need to know? Those are some of the questions I would recommend asking in the first trimester. Now, second trimester, which goes up to about 27, 28 weeks, you should ask about vaccinations. There are certain vaccinations that we recommend in pregnancy, like the flu vaccine and Tdap, which is tetanus, diphtheria, and pertussis. So you want to ask your physician or your midwife, what vaccine should I get in pregnancies? You might want to ask them what pregnancy symptoms are normal and what things might constitute an emergency. So decreased fetal movement for us is a big deal. Sometimes patients or women might not realize that not feeling your baby move for a whole day is a big deal. So you want to talk to your provider about those things that might impact what's normal and what may not be normal. You might want to talk about breastfeeding. What kind of supports are available for breastfeeding? And then you want to ask them maybe what the symptoms are of preterm labor. What does that look like? Once you get into the third trimester, that's about 28 weeks and beyond until delivery. Nice things to ask is, hey, what should I expect on labor and delivery? Another question would be, what happens if I don't deliver by my due date? So after I reach my due date, if I don't deliver, what happens? I can't tell you how often patients come in for an induction, right? And they think it might happen quickly, but inductions can actually take days to happen. So you want to ask those questions so you know what to expect on labor and delivery. You know what to expect in terms of pain management and just the experience in general. Another question you can ask is, can we discuss my birth plan? So if you've a birth plan, that's an ideal time to discuss that with your physician or your midwife. Find out, hey, what does this mean? What should, is this a good thing to do? So those are just some of the things that you could ask. Also, when to call. I say that's the last thing I tell my patients. Usually 4 reasons why we want you to call, especially at the end of pregnancy, right? If you break your water, if you don't feel movement, if you're having bleeding, or you're having regular, frequent, painful contractions. So you want to know when to call your doctor and how to get in touch with them. So the doctor-patient relationship is really an important one. And you want to make sure you find somebody you're comfortable with and the person that hears you.
That's great. Thank you so much, Dr. Thornton-Davis.
Thank
And Dr. Sandy, this is kind of a big question. We talked about the rising rate of maternal mortality and the increasing racial disparities. Can you just kind of go through what are some of the top causes of maternal mortality, and then some of the reasons why these disparities exist?
Yeah, that is a very big question, and the answer does vary a little bit whether you're looking at the United States versus the world in terms of the top causes of maternal mortality. But I'm going to list some causes that they may fall in different ranking lists, but they are the majority of the causes of maternal mortality. And when we're talking about maternal mortality, we're talking about moms that don't make it through the childbirth process, and for one reason or another, they pass away, whether or not their infant survives. So one of the main causes of maternal mortality or maternal death is severe bleeding or hemorrhage. So during childbirth, there's a lot that takes place, and you may be familiar with the afterbirth of the placenta has to come out and the uterus has to contract down. A lot of things have to happen to make sure that a woman doesn't bleed. And if anything interrupts that kind of progression, it can cause very severe bleeding. And in places where you may not have as much access to blood products, IVs and ways to resuscitate or support a woman who's losing a lot of blood, this is one of the major and leading causes of maternal mortality. Another major cause is what we call hypertensive disorders. These are disorders where the blood pressure goes up. Sometimes women may have existing high blood pressure going into pregnancy, and it can get worse. Sometimes women don't have high blood pressure at all, but they can develop conditions like preeclampsia or even eclampsia, where you may also have seizures. These conditions where the blood pressure is really high, it affects multiple organs in the body. And when those conditions are not able to be controlled, they can progress and lead to death. Another one that, maybe depending on where you live, you may not think about a lot is unsafe abortions. A lot of women access abortion care, whether it's legal, illegal, whether it's regulated or unregulated. And a lot of times when they're not in the hands of a skilled practitioner who's taking care of them, this is one of the leading causes of death around the world. And so when women don't have access to contraception, they don't have access to safe family planning care, this can be a major cause of death. And then when a woman is going through labor, and there are now problems with labor, and we have what we call obstructive labor, where they're just, the baby's not coming out. Sometimes if there's not access to ways to, enable a delivery, whether through operative means, helping assist the delivery through the birth canal or the vagina, or, through something like a cesarean section, this can also lead to maternal mortality. Now, the question about the stark differences when you look at maternal mortality rates, when you look at people of color, like specifically African-American women, and compare them to other groups, it is very striking. And even when you control for multiple factors, so even if you take women who have the same insurance coverage, the same income status, they're the same age, they have the same kind of medical problems, you still find that difference persists. And there's a lot of work going into looking at why. Why is that? You know, especially if two women come into the same care delivery system, they should have the same outcomes in theory. But when you start digging into it, you will find often that, you know, for African American women and women of color, a lot of times things come down to biases, and whether implicit or overt biases that are in the healthcare system. It comes down to listening. I think Dr. Thornton-Davis might have just mentioned, you know, when questions to ask your, you know, your OBGYN or your nurse, your certified nurse midwife when you're getting prenatal care, listening to a woman who has is going through her pregnancy or who has just delivered is so important, because when you look back and you say, what happened in this case where there was a poor outcome or a death, often a woman will have started expressing, you know, problems. You know, I'm having problems breathing, I'm having headaches, you know, I'm not able to see well. And those concerns aren't heard by the people who are caring for her. By the time those symptoms are acknowledged, it's often too late, and interventions at that point are simply not effective. So, you know, that's one of the main reasons that we see these differences. I think one of the biggest and the most important things that we can do as a healthcare delivery system, and as you know, when we're looking at where we receive our care, is for that acknowledgement to take place, that these problems are there, and then to specifically focus on them, to eliminate them, to eliminate biases, to make sure that the care that's being delivered is consistent and the same. You know, care does need to be tailored to each individual, but the overarching tenets of what the care that's provided during pregnancy are the same, you know, from patient to patient. And we need to make sure each and every time that care is being delivered, that's done. And when you are receiving care, you know, making sure that you understand exactly what's happening. And if you feel that you're not getting heard, if you feel that your symptoms are not being taken seriously, if you feel dismissed by your care team, please seek out assistance elsewhere.
Thank you so much, Dr. Sandy. And that's such a great point. And kind of going back to what Dr. Thornton-Davis said about the importance of that relationship with the caregiver, is you've got to have that trusting relationship and make sure that your concerns are being adequately addressed. So Dr. Knight, what are some of the most common complications that you see during pregnancy, and how do you manage those?
Right, thank you. That is also a very broad topic. As a physician who specializes in high-risk pregnancy, there's certainly a lot of complications that can occur. Fortunately, most pregnancies are healthy and don't have complications, but unfortunately, there is a significant portion that do have complications, and that's really what we're all here to try to improve outcomes and reduce the risks from those to both mom and to babies. Typically, I like to categorize different pregnancy complications really into three buckets. One are complications that really just affect the fetus. So that could be things like birth defects or anomalies, growth abnormalities. Either a baby is growing too slowly or is growing too quickly and is too big. There's complications that fall into the maternal or mom's category of chronic illnesses that she may have, or illnesses that she develops during the pregnancy, like Dr. Sandy mentioned, developing preeclampsia. Those are conditions that certainly affect both mom and baby, but those are typically more maternal illnesses that can have harmful impacts on a developing fetus. And then the other complication are really obstetric or pregnancy complications. So that would be things like hemorrhage, abnormalities with the placenta, preterm delivery, those kinds of things. In terms of how we manage them, as I'm sure you can imagine, management is very different depending on which issue it is that we are managing. All in all, the goals are to monitor closely, no matter what problem it is. we're monitoring mom. That can be through blood pressure, frequent checks with her OBGYN or maternal fetal medicine physician, lab work. It could be close monitoring of the fetus. And really, the monitoring provides us information as to how mom and baby are doing. Is it safe to continue the pregnancy, or would it be safer actually to deliver? In general, we try to prevent preterm deliveries as much as possible because of complications that can occur for a newborn that is born prematurely, but sometimes that's actually safer, and the risks of being born premature are lower than the risks to the mom and baby if the pregnancy were to continue. So certainly each individual problem has its own management strategy, but those are really the core tenets is how do we keep mom and baby safe and get the best outcome possible. In terms of the most common complications, since really our focus here is on improving maternal health and outcomes, of the different pregnancy complications that can occur, as Dr. Sandy mentioned, the most common that pose a short-term risk to a mother are hemorrhage or bleeding, typically at the time of delivery or shortly thereafter, or high blood pressure complications. Those are certainly the most common complications that we see that can cause harm to our patients. And then in the long term, there's actually a growing focus, which is really important, starting to look at what complications in pregnancy actually being risk factors for long-term risk complications for medical complications down the road. So for instance, we all know that high blood pressure in pregnancy increases your risk for high blood pressure later in life, same thing with diabetes. But what is not as well known is that having a preterm delivery or having a baby that was smaller than expected during pregnancy, those are also increased risks for long-term cardiovascular complications. So really important getting that message out and making sure that we are following women and doing everything that we can to try to reduce their risk of long-term complications.
Great. Thank you, Dr. Knight. And Dr. Emarievbe, what about during labor and delivery, where a patient, may not be seeing the same provider that they saw as an outpatient? So they're having to kind of, make that quick bond or relationship with a new team of caregivers. How should patients self-advocate in that situation?
Yeah, I think it's really important to Dr. Thornton-Davis's earlier point about establishing that trust relationship. And I think you can develop that trust relationship even on labor and delivery, not knowing the patient prior to that day that they come on. And it's really just about being available to your patient, letting them know that you're part of their journey with them to ensure that not only that their baby is delivered safely, but that mom and family and all those who are there to support her are part of this journey as well. So I do think that shared decision-making is of utmost importance. I oftentimes will talk to patients that I never met prior to being on labor and delivery. And I always tell them, listen, if something doesn't make sense, if you thought the plan was going this way, but it's not going that way, I'm here. Call me. Your nurse is here. Oftentimes when I'm signing the consent with the nurse in the room. I'm involving everyone, family members, mom, dad, grandparents, whoever's there, as part of that team to say we're all part of the same team. So shared decision-making is very, very important to ensure that even though you don't know the OBGYN that's there to take care of you on labor and delivery, you can really establish that trust relationship quite quickly. I think familiarity from the provider's standpoint really helps to build that trust relationship. When I can come into a room having already reviewed a patient's chart, and I know all the things that that patient had going on during the pregnancy, I think it's really important to the family to know that the provider that's taking care of them is familiar with their history, familiar with their pregnancy course, because a lot of patients do come in with some type of of apprehension of not having their own OBGYN who's been following them through the course of their pregnancy, they're in labor and delivery. And so when you do come in and say, hey, Ms. Jones, I know that you had to get an ultrasound a couple of weeks ago and they were looking at the growth of baby, but everything looks great. I think that gives them a sigh of relief that, wow, okay, we are doing this together. I'm part of this journey with this OBGYN. Even prior to showing up on labor and delivery, consistent prenatal care on the part of our patients helps to really improve our outcomes on labor and delivery. Oftentimes we're able to identify in the office visits if you do need to be induced early, if you need to come to the hospital early, if there's additional tests that need to happen prior to. We don't want day of your arrival to labor and delivery to find out there was an ultrasound that should have been done or there was follow-up that should have been completed that was not done. So I think that advocating for yourself is also represented by consistent prenatal care. To Dr. Thornton-Davis's point, come with your notebook, ask all your questions. I prefer you asking those questions in your 20-minute appointment than not knowing what's going on the day of your delivery at the hospital, where things can get kind of busy and you don't really understand why you're there. So I think having consistent prenatal care helps with that. Communication goes with shared decision making. I think, discussing your health outcome, your health concerns with your provider right away. When you hear stories of Black and Brown women who have gone through very challenging deliveries or have had a bad outcome, one of the main things that they say is, no one listened to me. I was saying this thing and I felt this way, and maybe I wasn't able to verbalize what I was feeling, but I did not feel heard. I did not feel like the provider really understood what I was saying. And so communicating and offering a space for your patients to communicate, letting your patients know, hey, you can reach me at any time. I'm here on labor and delivery. If something doesn't make sense, just let me know, let your nurse know, they can reach out to me. So I think communication is a really great way to advocate. And then knowledge, I think on the part of our patients to do the research, to the points of Dr. Knight and Dr. Sandy, like knowing what those risks are. What are the risks of, having gestational diabetes? What can I do even if I do have gestational diabetes to ensure that I don't have a poor outcome? Moms who have gestational diabetes are at increased risk of having big babies. And, sometimes those babies are at increased risk of not getting out of the vaginal canal safely, resulting in what's known as a shoulder dystocia, where the baby can get stuck, or a need for a C-section. So kind of understanding what complications can arise during the pregnancy and even intrapartum during the labor course will also help you as a patient to advocate for yourself.
Great. Thank you, Dr. Emarievbe. Back to that theme of communication, right? And self-advocacy, so important. Going to switch gears now a little bit to postpartum. So Dr. Thornton-Davis, we know that a significant percentage of maternal deaths actually occur in the days or weeks after delivery. When everyone may think, okay, mom and baby are safe and all is good, but we know that some severe complications can happen after that point. What are some of the warning signs that women should be looking out for in the immediate postpartum period?
Yeah, that's a good question. I mean, I think it's good to think of labor and delivery and the postpartum period on a continuum. So, delivery doesn't mean it's all over. The postpartum period, is not really accentuated by that postpartum visit. I just have to do that postpartum visit. It should actually be seen as an ongoing process through, 12 weeks after delivery or following delivery. And if you have any concerns after delivering a baby, always reach out to your physician or midwife, because something that you might think is mild or minor might actually signify something greater going on. So some of the things that you might want to be aware of in the postpartum period are those chronic conditions that Dr. Knight, Dr. Sandy, and Dr. Emarievbe just talked about. Did you know that in the postpartum period, postpartum hypertensive disorders are a big thing? Women can develop lots of symptoms, things like chest pain, or shortness of breath that develop in the postpartum period, seizures, these types of things. You should always reach out to your healthcare professional to discuss. You can develop preeclampsia or that hypertensive issue that you can develop in pregnancy, you can develop that after you deliver as well. You can have a stroke following pregnancy, because your pressures are too high. You can develop something called cardiomyopathy, where your heart muscle is just working really hard and to pump, and that can be something that's deadly. You can develop blood clots following delivery. So anything that feels not right, you want to follow up. I always say after you deliver a baby, you should always feel better, never worse. If you feel like you're getting worse after you deliver a baby, don't hesitate. Don't think that you're bothering your physician or your midwife. We want to know. We want to know how you feel. Other things that we commonly see in that postpartum period are postpartum mood and emotional well-being issues. So lots of women experience the baby blues, which is kind of a down mood, where you feel like you can't do things the way you normally did it. And that can be normal for about 6 weeks following delivery, where you just don't feel quite like yourself. And that can be attributed to the transition from going from having no kids, 2 kids, or having 1 baby to 2 or 3. So some degree of down mood and transition is normal, but those symptoms really should kind of go away after about 6 weeks or so. If you notice yourself feeling down and out after that period of time, you could be developing postpartum depression, which is something a little bit more serious, and that might need treatment. It might need medication. It might need therapy. So always reach out if you aren't feeling great. At your postpartum visit, we typically assess for that. We do screening tests to see if you're having issues with depression or anxiety. So don't hesitate to reach out. At the extreme end of things, some women can develop something called postpartum psychosis. It's not very common, but it could be very serious and life-threatening. So if your mood just doesn't feel right, if it doesn't feel like you're getting better, again, reach out to your physician or your midwife. Another thing that you can commonly see in the postpartum period are infections. So if you develop a fever after delivering a baby, if your uterus feels kind of tender to touch, you just don't feel good. Don't hesitate to come in, because infections can be seen after delivery as well, not just during delivery, when you go home. We talked about bleeding disorders. Dr. Knight talked about excessive bleeding. You can see that actually in the postpartum period as well. I myself had a delayed postpartum hemorrhage. So you can have heavy bleeding following delivery that should be addressed. So if you're bleeding and you're changing pads, see your provider. Those are just a few of the things that can happen in the postpartum period. And actually, there's one other thing I want to bring up is kind of issues or problems with breastfeeding. And so lots of women want to breastfeed, and we want to encourage breastfeeding for, women. So if you have, issues with breastfeeding, you want to reach out as well, because there are lots of resources to help you or to kind of get you on the right track with breastfeeding, because it can be stressful to have an infant and you don't feel like you're able to produce what you need to. So, common breast issues, you can have mastitis. That's another infection. So if your breasts don't look quite right, you want to be assessed. You could also have clogged milk ducts that can cause pain and cause issues with breastfeeding. So issues with breastfeeding can be looked at, and we encourage women to reach out just like they did in pregnancy if they have an issue in the postpartum period, and follow up with your providers, because we want to see you in the postpartum period as well. That's just as important as pregnancy.
Yeah, absolutely. Thank you so much, Dr. Thornton-Davis. Really great points. And Dr. Knight, what about COVID-19? How has that impacted maternal health? And what can we do to increase the rate of vaccination and keep pregnant people safe?
So COVID-19 certainly had a tremendous impact on our patient population. We've all on this call experienced that in the last few years. The fact of the matter is, women who are pregnant, typically, this is true for all or the majority of viral illnesses, can have a more severe response. So women who contract COVID-19 when they're pregnant or shortly after a pregnancy are at higher risk for having severe disease. And severe disease in extreme cases can look like respiratory failure, need to be in the ICU on a ventilator, need for ECMO, or even, there have been pregnant women who have not survived pregnancy or the postpartum period because of complications related to COVID-19. And even women who do not become severely ill but contract COVID-19 when they're pregnant, we are seeing an increased risk of preeclampsia, growth restriction in the fetus, preterm delivery, and stillbirth. So Really important that we educate women on these risks. Dr. Banulis, you asked about how do we increase rates of vaccination, and really it comes down to counseling and communication and educating our patients. A valid question many patients have is the vaccine safe? Part of the challenge with how clinical trials are run in this country is we do not include pregnant women. So we don't have data on pregnant women on clinical trials looking at vaccine safety. However, what we do have is outcome data on tens of thousands of women who have received the COVID-19 vaccine in pregnancy, either knowing they were pregnant or not knowing they were pregnant. And at this point, we have a everyday growing body of data that tells us that we are not seeing an increased risk of pregnancy complications in women who have been vaccinated. On the flip side, we're actually seeing better outcomes. So better chance of a full-term delivery, better chance of developing a healthy newborn, lower chances of complications like preeclampsia and growth restrictions. So really the key is to educate our patients on the risks of COVID-19 in pregnancy, just really underscoring the fact that it can be a very bad actor. A lot of people rely on the fact that they're young and healthy and think that if they get it, it's just like a week with the flu, which for many it is, but for some it's not. And then just continue to have that conversation about how safe and effective the vaccine is.
Great, thank you. Thanks so much, Dr. Knight. And we have time for one more question. And Dr. Sandy, this is something you alluded to briefly earlier, but can you tell us just a little bit about what is the importance of access to family planning tools and preventing adverse maternal outcomes?
Yes, access to family planning tools is critical. Giving women the choice and control over their reproductive health is really crucial to improving maternal mortality. And a lot of times, we don't think about it that way, but if we allow women to make informed choices and have access to family planning methods and contraception, which helps prevent pregnancy, so that they're not in a position of having a pregnancy maybe at a time that's not working, or they're medically not ready to carry a pregnancy. We reduce the risks that are associated with pregnancy during that time. And we also reduce the risk of women accessing termination of pregnancy in a manner that is just not safe. And unfortunately, with the changes in access, and when you look around the world, access varies wildly from country to country, and even in the United States, from state to state, it varies to what women can access and what they can safely do. So if we allow women that control, trust them, they're women, they know what they need, and allow them access to contraceptive methods, to family planning resources. And often when people think about contraception, they immediately think birth control pills, but there's so much more out there that is available. And there are even non-hormonal methods that are available. There are methods that don't use any type of intervention besides their things like tracking your menstrual cycle. We call that the fertility awareness method, that a lot of women simply don't know about. So giving women access to these very vital resources will absolutely reduce maternal mortality and put more control in women in charge of their own reproductive lives.
Great. Thank you so much, Dr. Sandy. And thank you. We are out of time. Thank you to all of my amazing colleagues, not only for taking time out of your busy practice to join us today, but also for just providing such respectful and compassionate care to your own patients. And thanks to everybody who joined us today. If you enjoyed this conversation, please share it with your friends and family. You can follow us on Facebook, Twitter, LinkedIn, YouTube, and Instagram. And you can learn more about our integrated multi-specialty medical practice and find lots of great health information on our blog at kp.org/doctor. So from all of us at the Permanente Medical Group, be well.